Hi, welcome to POC Nurse, that's Point of Care Nurse. My name is Gozi, and today we're talking about aneurysms for the CCRN exam. So, an aneurysm is pretty much an outpouching or dilation of the wall of an artery. So, it's kind of like you have something going in a straight line, two straight lines on the side, and then on one side you have like a circle growing out of it. So it's like an outpouching or dilation of the wall of an artery. Um, there are different types of aneurysms. You have false aneurysms that doesn't involve all the layers of the artery. You have true aneurysms that involves all the layers of the artery walls. You also have saccular aneurysms, which is an outpouching from an artery wall due to thinning and stretching of that particular area of the artery wall. You have a fusiform aneurysm, and this one involves the entire circumference of the artery, and there's diffuse dilation all around this artery wall. And then we have a dissecting aneurysm. This is when like a hole or a space or cavity is formed because there's a tear in the layers of the artery wall. So then you have blood accumulating in that area and making it bigger. This is how we get a dissecting aneurysm. We also have ruptured aneurysms where the artery wall ruptures and leaks blood into the space where it is. If it's uh, if it's a thoracic um, aortic aneurysm, it leaks blood into the chest or into the abdominal cavity if it's an abdominal aneurysm, an abdominal aortic aneurysm. So, aneurysms are caused by several things. They can happen due to the aging process where things get weaker, not as elastic as before. So, the walls of the artery could get weaker, be stretched out, and more prone to outpouching or dilation. It could happen because a person has a genetic predisposition to having artery walls that are weak. So, a congenital weakness of the aorta, it could be because this person has hypertension and those vessels are constantly under high pressure, so they become weaker and then they can have an outpouching. It can happen due to pregnancy. In pregnancy, women have an increased blood volume circulating through the body. It could happen because of syphilis, severe systemic infection, Marfan syndrome, trauma. It could happen due to coarctation of the aorta, and it could happen because the artery has been cannulated, such as when the patient goes to the cath lab for PCI or when a balloon pump, intra-aortic balloon pump, is placed in the patient. Obesity, smoking, and atherosclerosis could also cause an aneurysm. So, when we talk about symptoms of an aneurysm, patients are usually asymptomatic when the aneurysm is not dissected, which means there is no tear in it. So, blood is flowing through it, there's just an outpouching. But when there's a dissection in the aneurysm, the patient will present with symptoms. So, but when or if the aneurysm ruptures, the patient will also present with symptoms. Now, rupture is not good. Now, some of the symptoms that the patient will present with could be a normal or high blood pressure or hypotension, in which case this patient might have had an aortic rupture or cardiac tamponade. You might find a pulsatile mass in the patient, increase aortic diameter when you palpate, and you could also hear a bruit over the aorta. Now, there are, for the purposes of the CCRN exam, we're going to talk about the two types of aneurysms regarding the aorta. We have an abdominal aortic aneurysm, and we also have a thoracic aortic aneurysms, and the symptoms are somewhat different. And it's important to know the presenting symptoms of the two. Now, if a patient comes in with an abdominal aortic aneurysm, if the aneurysm is small and intact, they might have no symptoms like we spoke about before. Now, the patient may have pulsations in the abdominal area, so that aneurysm could be pulsing, and that pulsations could be seen or felt over the patient's abdomen. Now, the patient could also complain of abdominal or lower back pain, nausea, and vomiting. This patient could go into shock. We had a patient come in one time when I worked in the emergency department. I was working in a small community ED. So this guy came in, looked like a homeless guy, complaining he had back pain, but he looked like he was in serious pain. So we're wondering what could it be? He's having back pain. He kept saying he was in pain. He went for imaging studies. He never came back. Turns out this guy has an abdominal aneurysm. I think they took him to the OR from there. He didn't come back to the ER. All right. So we just spoke about abdominal aortic aneurysm. Next, we're going to talk about the thoracic aortic aneurysm. So the abdominal aneurysm obviously is in the abdominal area, and the thoracic aneurysm is going to be in the chest area. So this patient most likely is going to complain of chest pain. So the patient might complain of chest pain that started suddenly, feels like a ripping or tearing in the patient's chest. Patient might also complain of a cough. The patient might complain of having difficulty swallowing, difficulty breathing. Patient might have uh, dizziness. Patient might report that it's hard to walk, and it might be difficult for the patient to speak also. Patient's voice might be hoarse, and if you do a chest x-ray, you see a widening of the patient's mediastinum. So this is how to differentiate between, is the patient having does the patient have a thoracic aortic aneurysm, or does the patient have an abdominal aortic aneurysm? So treatment of aneurysms might involve monitoring, or it might involve surgery or medications. So if the aneurysm is less than 5 centimeters and the patient is asymptomatic, the patient is monitored, the aneurysm is frequently scanned to check for growth. The patient with hypertension is also treated so that that aneurysm doesn't get any bigger. And people with Marfan's syndrome usually get treatment earlier just because they're predisposed to aneurysms. Now, um, indications for surgical intervention include when the ascending aorta is involved or there's aortic insufficiency. When, for example, the patient that is hypertensive and is being treated to prevent growth of the aneurysm, when that drug therapy doesn't work and the obviously the aneurysm gets bigger or starts to get dissected, and that dissection gets bigger, obviously the patient's going to need surgery. Also, when the patient develops cardiac tamponade, surgery is indicated, and if a major branch of the aorta is compromised, surgery is indicated. If there is any cerebral or cardiac ischemia, the patient gets surgical repair for the aneurysm. We're going to end this portion of the CCRN review by talking about dissections. We spoke about dissections before as being a tear occurring between the layers of the arterial wall and then blood collecting in that area. So in aortic dissection, we have blood passing through um, the layers of the aorta. In this case, we're talking about aortic dissection. In this case, we have a tear in the aorta, and between the layers of the aorta, and blood is collecting in this area. So this is an emergency. It needs to be fixed right away. So the tear is usually spiral in nature. It can come on suddenly, or it can take its time and occur over time and slowly get bigger and start causing problems. It usually will occur in the ascending aorta or in the aortic arch. It is life threatening, like we talked about before, and requires immediate medical attention. So, in this portion of the CCRN review, we spoke about aneurysms, which focus mostly on the thoracic aneurysm and the abdominal aneurysm, which have different symptoms for the most part. We talked about ways patients could develop an aneurysm and treatment for the aneurysm. It could be just monitoring with medications at home, or it could be surgical repair. This brings us to the end of the cardiac portion of this CCRN review. So what I'm going to do is make a playlist with all the study guides for the cardiac portion of the CCRN exam, and you can just put it on and listen to it while you're, doing something, doing laundry, driving, being busy, but also being able to study. That's one of the reasons why I started making these audio study guides, because when I took my CCRN, yeah, I'm still busy. I had a very busy life. I had kids. I get off work, take them to school, come home, cook, clean, sleep. I work the night shift and pick them up, get them settled, go to work. So what I did to prepare for the CCRN review was to listen to as many things as I could. I listened to things while I was driving. I listened to things at the job when I had downtime, when I was on my break eating. I would listen while I was doing laundry, while I was cleaning the house. It was very helpful to me because I couldn't find time to sit down and study for long periods of time. I did have to study. I read a book. I used some review books. I used about two or three review books, and I did questions online. So all of those things helped me. But by far, I think listening to reviews were the biggest things, because I was now able to go into the books, connect what I read, what I heard with what I was reading, and go through the books a little bit faster. So I hope you find these audio study guides helpful. And please like, share, and subscribe. And I will see you in the next series, which will be for pulmonary. All right. Bye bye. Take care.